Hi, good afternoon, everybody. So I'll be talking about the treatment of first-line therapy in EGFR mutant advanced lung cancer. And we're looking at either Osimertinib or Decotinib. And this is what we'll be talking about, the efficacy, side effects, and tips for selection of patient. Now, as we know in the previous talk and from before, that in Indian patients, approximately 25% of patients harbor an EGFR mutation. The common mutations being exon 19 and deletion, and exon 21 L858R point mutations. These are also called canonical mutations. Now, these mutations are located in the tyrosine kinase domain and result in increased kinase activity of the EGFR, leading to continued cell proliferation. And we have various drugs inhibiting them. There are notably 3 generations of drugs. The first generation EGFR TKIs, notably Erlotinib and Decotinib, which bind reversibly to the wild type as well as the mutant EGFR and don't have any activity with regards to T790M. We then come to second generation EGFR TKIs, Afatinib and Decotinib, which are irreversible EGFR TKIs, and they have a broader spectrum of action. They are active against all 3 members of the ERBB family, that is EGFR, HER1, HER2, and HER4. And they also have activity, maybe some preclinical activity on T790M, but it's only preclinical. We don't know clinically. So there is a potential in these drugs for more complete inhibition of this signaling. Coming to Osimertinib, this is a third generation EGFR TKI, and that has it's more selective. So it has less activity against wild type EGFR, hence less side effects, and more activity for exon 19 and L858R, and as well as T790M. So various trials have looked at these drugs in as compared to chemotherapy or against each other. However, and starting from first generation to second to third generation, for us, for today's talk, we will be talking about Decotinib and the Archer 1050 trial, as well as the Flora for Osimertinib. And as you can see, PFS and OS has been increasing from first generation to third generation drugs. So coming to Archer, this was a multi-center randomized open-label phase 3 study, which looked at patients who were treatment naive with advanced NSCLC who harbored EGFR activating mutations with a good performance status. And notably, they did not take patients with any CNS metastasis. And they randomized these patients, stratified them as per their race as well as the EGFR mutation type to either Decotinib 45 mg/OD or Decotinib 250 mg/OD. The primary endpoint was PFS. The secondary endpoints were PFS by investigator assessment, overall response rate, DOR, TTF, overall survival, safety, and patient-reported outcomes. Sorry. Yeah. So coming to the efficacy, PFS was definitely higher in the Decotinib group. That was 16.6 months as opposed to 11 months in the Decotinib group. Looking at the response rates were, they were slightly higher, 75% versus 72%. However, this was not statistically significant. So looking at the overall survival, if you look at the survival at 31 months, it was again followed up, and final OS was at 47.9 months. And this was longer in the Decotinib arm as compared to the Decotinib arm. That was 34 months versus 27 months. Point to be noted is that there was a hierarchical testing, statistical testing, which was done for Archer. So they looked at PFS first. If it was significant, then they looked at ORR. If it was significant, then they looked at OS. Now, because the ORR was not statistically significant, although the OS was, the p-value was good, it was significant on its own, but the gatekeeping procedure stopped the statistical significance testing for OS because of this particular reason. So it wasn't really formally assessed. Coming to different subgroup analysis, most subgroups seem to benefit from Decotinib over Decotinib. Patients who were more than 65 years of age or equal to 65 years of age didn't seem to do that well with Decotinib. And however, if you look at the Asian versus non-Asian and the EGFR subtype, they both seem to derive benefit. Coming to the exon 19 deletion mutation, the benefit was not really significant for the HR. However, and it was quite significant for those with exon 21 L858R substitution mutations. There are 2 thoughts about this. One, that the del19 mutation anyways is a very sensitive mutation. So, we can't really say much about whether, that's the benefit not being significant with Decotinib. And secondly, L858R mutations have very poor outcomes with Decotinib. So the overall survival was only 23 months. Coming to, well, this drug did need dose reductions. That is Decotinib. I'll come to that later. They looked at those patients where dose reductions were done, and the survival benefit was maintained in those drugs. In fact, numerically, if you look at the second one, those patients who had dose modifications seemed to do even better than those patients who were on the upfront 45 mg dose. But this is a unplanned subset analysis, so we take it with a pinch of salt. Coming to side effects, so Decotinib is a toxic medication. Most frequent side effects are diarrhea, paronychia, dermatitis, mostly acneiform, and stomatitis. And as compared to Decotinib, which is mostly some bit of diarrhea and AST/ALT elevation. So grade 3 toxicities were definitely higher. There were more rates of dose reductions for Decotinib, nearly to the tune of 66.5%. And a second dose reduction was seen in almost 27% of these patients. If you look at the permanent discontinuation rates, they were 10% versus 6.7%. So did not really lead to a huge discontinuation rate. Coming to, and this is an important slide, if you look at the next treatment that these patients received, only 10% of the patients in both the arms went on to receive a third generation EGFR TKI. So we'll come to that again in a while. And subsequent therapies were received by around 57% patients in the Decotinib arm and around 65% patients in the Decotinib arm. So we stopped for Decotinib. Coming to the FLORA trial, which was a double-blinded phase 3 trial looking at Osimertinib. Again, similar subset of patients with one notable difference. That is, they included stable patients with CNS metastasis. They were again stratified by mutation status and race to Osimertinib 80 mg OD for the first generation TKIs. And coming to the efficacy, so there was a PFS benefit, 18.9 months for Osimertinib versus 10.2 months for the comparator arm, with a very good hazard ratio of 0.46. Seemed to do well in mostly for Osimertinib in most subgroups. Coming to overall survival, there was again an overall survival benefit for Osimertinib, 38.6 months versus 31.8 months. This was statistically significant with a 20% lower risk of death. Notably, there was a crossover in this trial. So in spite of crossover, there was a statistically significant survival benefit. At around 3 years of treatment, around 28% of patients were still continuing to receive the drug, as opposed to 9% of patients who were receiving first generation TKIs. So this is the subset analysis from the FLORA trial for the overall survival. So CNS metastasis, patients did well whether they had CNS mets versus no CNS mets. Coming to the mutational status, so those patients who had L858R mutation did not seem to derive so much of benefit. There's been a lot of debate going on about it. The data is quite, well, it seems to be compelling. But if you look at the overall PFS in all the three trials for second and third generation EGFR TKIs, numerically the PFS for Osimertinib is still higher. Also, there was some subset analysis which looked at Asian patients not really deriving so much of benefit. As a secondary endpoint, this trial was not really powered for that, so we can't really say much. And subsequently, there was a Chinese FLORA trial, which you would be aware of, where again they looked at the OS in patients, Chinese patients, mainland China patients, and then there again seemed to be a benefit for Osimertinib over the first generation TKI. So almost 50%, again, similar to the previous trial, patients received subsequent therapy. For Osimertinib, 70% of them received chemotherapy. And for first generation TKIs, 65% received subsequent therapy and around 47% received Osimertinib. Approximately overall, only 30% received Osimertinib. And we know that T790M mutation can come up to 50% in these patients. Half of these patients also went on to receive further subsequent therapy. Coming to adverse events. So again, most common reported adverse events are rash or acne or diarrhea and dry skin. Mostly grade 3 adverse events were similar between the two arms, the rates as well as the rates of treatment discontinuation. If you look at the grade 3 adverse events for diarrhea, rash, nail changes and dry skin, they're not very high in the Osimertinib arm. 1 point QT interval, 10% prolongation in Osimertinib as compared to around 4% in Decotinib or Erlotinib. So what do the guidelines say? The guidelines recommend you can give either osimertinib or any of the other TKIs as a first line. Dacomitinib and osimertinib are both category 1, but osimertinib is preferred. So the big question, how do we select our patients? What approach? Do we go for a sequential approach? Do we go for an upfront third generation TKI approach? Which drug do we use first? So honestly, more questions than answers. There's no one right answer. We don't have a randomized trial which has compared these two drugs together. So we'll wait for more data to come in, especially longer follow-up or maybe data for, what happens beyond osimertinib, which is the topic of the talk today that we're going to be hearing. And so what it eventually boils down to is we look at the personalized approach for each patient. We look at multiple factors, that is the systemic anti-tumor activity, impact on use of subsequent anti-cancer therapies, the CNS activity, which is very important, as well as the tolerability, I can't pronounce that, of the drug. So it's important to look at your patient. It's important to look at the performance status of the patient, to look at the age of the patient, look at comorbidities, look at drug interactions, and more importantly, cost is also a factor because osimertinib is expensive. So I'll skip this slide. I'll just mention that overall response rates are mostly the same in both. Anti-tumor activity in terms of survival seems to be better. We don't have a randomized trial. The sequential approach is also good. But we don't know much about it in terms of Decotinib because only 10% of these patients went on to receive subsequently Osimertinib. So let's see. Coming to CNS activity, there is definitely a CNS activity seen with Osimertinib. There is activity with leptomeningeal disease also. In fact, we published a paper where we looked at 16 patients with leptomeningeal disease, either first-line Osimertinib or a second-line Osimertinib. Response rates of almost 80% in the first line and 60% in the second line were seen. Bloom trial was also there with good response rates, as well as the Aura trials also looked at leptomeningeal disease in certain patients. If you look at the CNS activity, so median PFS of those patients who had CNS metastasis was similar, around 15.2 versus 9.6 months. Coming to toxicity, again, I've put them all together. So out of the 3 or the 2 drugs that we're talking about, osimertinib seems to be better tolerated with less dose reductions, only 4% as opposed to the other. And however, if you look at the treatment discontinuation rate, it's not really very different. So eventually coming to the tips and tricks and the clinical things that we look at when we're working with our patients, we look at various other things also. We look at whether there's a PPI interaction or a pantoprazole interaction. So osimertinib, there's no interaction. Decomitinib, you have to avoid concomitant use. You can still give ranitidine and H2 receptor antagonist, but you have to give a break between the drug and the 2 drugs. Notably, hydroxychloroquine, the protocol says you avoid osimertinib for 4 months if the patient is on hydroxychloroquine. In fact, for a couple of our patients, we did not give them because there's a very high risk of QT prolongation. Dacomitinib has no such interaction. If you look at ATT, again, more interactions with osimertinib. So you can give, but use with caution. And Decomitinib, there's no significant interaction that we can find. So you can, probably be a little more less worried that there'll be drug interactions. There's no specific relation to food with either of the 2 drugs. Osimertinib is known to cause QT prolongation and cardiac dysfunction. So needs frequent monitoring. Dacomitinib, not so much. Coming to, yes, the uncommon mutations. So the most data is for afatinib, which is the only EGFR TKI which is approved by the FDA currently. However, there was a phase 2 trial of around, I think, 37 patients with osimertinib, and the drug seems to have activity against these mutations and can be considered as an alternative treatment. Just a couple more slides. And this is endorsed by the ESMO guidelines. For decomitinib, there is some data. It's coming in, seems to be active, but we need more data right now. Coming to toxicity management, so I'll keep this chart now. So you look at what the drug inserts say. Notably, for diarrhea and for skin reactions, you hold at grade 2. So that's important to know. And then you resume as per how the patient tolerates. For other things, these become important. How do you do? What do you tell the patient who's in the reproductive age group? So for you need to use contraception for at least 17 days after the final dose for Decotinib. There is more risk associated in the geriatric population. You have to monitor better. For renal and liver, the data is very sparse for both with for severe dysfunction. Coming to Osimertinib, you basically dose reduce if it's a grade 3 reaction or higher. And as I mentioned about the cardiac points, one last thing, with some of these patients, you need to give the drugs through Ryle's tube or through, they're on a liquid diet. So you need to know how to administer both these drugs. My last or second last slide is that it's very important to educate the patient regarding these toxicities. So information sheets are, you can do that. This is what we do in our OPD. We give this out with each prescription of Decotinib, Osimertinib or Afatinib. In the end, Osimertinib seems to be a better choice in a lot of aspects. Decotinib is one place where, say there's a young fit patient with an L858R mutation with, say, no CNS metastasis. That is one place where we would definitely maybe consider it more over Osimertinib. And it's an individualized choice. So thank you.
Thank you, Dr. Mansi, for that unbiased presentations, neither towards any of the TK. Okay, so next I would like to